Okay, now we can go ahead and get started. So I want to go ahead and introduce, we have some folks who are guests, and then we have a number of folks on our panel today. So I want to go ahead and get started with people who are new to the meeting today.
I will just kind of baby start this. I did invite a couple of my key guests just because we were doing the roundtable on medicine. So my partner in crime out of Penn State, Rob Gilio, is there. He's a retired pulmonologist. And I've got a strategic partner, Ready.net. He's the head of utility and public sector, Craig Corbin, that has a tremendous platform. So those are my kind of partners to the table.
Good, thank you. I appreciate you doing that. Anybody else who's new today?
Well, I am new.
Yeah, well, you're going to get introduced though, Mohan.
Okay.
You're one of our presenters today, so you're going to get seriously introduced. So I want to go ahead and share my screen. Hopefully I've got the right page. No, I don't. Stop share. Let me get back there to this page. There we go. Okay, now I can share my screen. Okay, there we go. So I want to, actually, I don't know if the folks from the broadband office are going to be here today. Cindy, I thought was going to be here. So we're going to just go ahead and jump into the program today because I got a little carried away and invited some really great people to participate on the panel today. So we have lots of people. So I want to just go ahead and get started. And then hopefully we'll have some time for some announcements a little bit later. So let me get up here so I can get into this. So I think many of you have been on the program before when we had Craig Settles, who was the nationally recognized broadband author, expert consultant, and telehealth advocate. And we're going to hear more from him, and he can introduce himself more in just a little while. And then no stranger to us is Janet Major, who, as you all know, is Associate Director for Innovation and Digital Health with the Arizona Telemedicine Program and the Southwest Telehealth Resource Center. Next up is Lucy Howell, who's the Managing Director for the Force for Health Network. And next is Dr. Golem. Is that correct, Dr. Payman, who's a retinal surgeon, professor, and director of research at the U of A College of Medicine in Phoenix with the Department of Ophthalmology. And then last but not least is Dr. Mohan Tanaru, who's, I'm making sure I got it all correct. And Mohan is an adjunct professor, in the Division of Public Health Practice and Translational Research in the Mel and Enid Zuckerman College of Public Health at the University of Arizona, and also a senior investigator in the Global Health Initiative at Henry Ford Health Systems in Detroit. And actually, Mohan and I go back many, many years when Mohan was the head of the MIS department at the U of A. So the focus of this program and the reason we have all these people is I wanted to talk about the intersection of technology and community health. And it certainly is consistent with the interest that we've had lately about particularly telemedicine and libraries. And so I think that a lot of the work that these people are doing will complement that work and will be a great resource for the work that we're doing. So with that, I'm going to just jump into introducing Craig. And Craig, if you just give us a quickie background and then share some thoughts with us, particularly as it relates to telemedicine.
Sure. I'm Craig Settles. I'm a consultant working with cities that want to have broadband in their cities. And I've been a very staunch advocate for telehealth, large part because I was saved from one of the from a stroke because of telehealth. The I mean, I can answer later. If people have any questions, I'll come back to that or the my background. But the thing I wanted to talk about quickly and get people to think about is maybe 8, 9 years ago, Arkansas had a problem where just about everybody who had a stroke in that state died. Large part was they couldn't get medical attention fast enough, and they couldn't, in particular, they couldn't get a particular drug that you need to get if you are a stroke patient, um, uh, because it was a rural state. There were only at the time 3 neurologists in the state. They were all together at one university hospital. Um, and they came up with this idea of linking the hospitals using a research network. They got space on that network, and they created a telestroke network. Um, the and they managed to have an increase of patients who then were able to survive. One of the issues with the medicine is that it's one of those things that can cure you or kill you, right? If you don't administer it correctly, it'll do the latter. And so rural doctors wanted no part of that or the liability, right? And so by pulling the different clinics and hospitals together, they were able to create programs and so forth for training to make sure that the doctors and nurses could administer the drug appropriately, that they could use the technology appropriately, and they added a additional service from the neurologists out to the hospitals to make sure that they were doing things correctly, and so they were able to reduce the number of deaths, and so that by itself was great. But the other element is they were able to create additional applications that were delivered over telehealth through that network, right? And the reason I bring this up is that every state is given or has been given money for middle mile networks. And when they announced that that they were going to do that, NTIA said, we would like to have other applications on top of those networks. And so, first thing I started talking about, I also had a conversation with NTIA person, to understand, what their expectations were. And so the ability, I think, for states, well, Arizona, to take that money for middle mile. If you do like in Michigan, the state of Wisconsin has an additional 3 $200 million additional network broadband funds, and they are also focusing a lot of that on middle mile as well, right? So I would say that to use that middle mile to anchor a telehealth network would be a good thing overall. The lesson I learned from Arkansas is, start with one application that everyone can fully, get behind and support, and then branch out to other applications based on, need and what the future could possibly hold and so forth. But I think that at the end, to create that kind of a strategy for using the middle mile network would have significant impact throughout the state. And then the last point, I'll let it go and then everybody else go, is that I've also thought of having the equivalent of like way stations, right? So in many of the rural areas, there may be 2-3 hours before you can get to a hospital or some sort of medical personnel, right? So even if the hospital, if the ambulance gets you in, get to you in time, if you have a serious issue, that could be, the distance between the 2 points could be a problem, right? And so I'm thinking if you had an office or like a gigabit network and so forth, and some sort of enclosure, right? You could stop if if a stroke patient or a heart attack person would go code blue, right? And it's like you're still an hour away from the hospital. Having this network of way stations could be literally life-saving. And I think that incorporated with this idea of having a statewide telehealth network, it has some value. Now I'll be quiet now. That's
Okay, thanks, Greg. I'm going to hold questions for now because I want to make sure we have plenty of time for all of our panel folks to do a presentation. So Janet, you up next.
Great. Thanks, Steve.
What an idea to have a statewide telemedicine network, huh?
Well, we are very fortunate here in Arizona that we've got people who have been doing great things in the world of telemedicine and telehealth, right? And I'd like to take a minute to share some hopefully new resources to folks who have been participating in this call, but also carry on the conversation about the whole idea of using technology in improving community health and using technology to create public spaces where people can have private conversations about their healthcare. And I would like to share a few. Can I share, Steve?
You bet. I'll stop sharing. Okay.
Okie dokie. For those of you who I haven't met, my name is Janet Major, and I work with the Arizona Telemedicine Program. We've been here for over 25 years at the University of Arizona College of Medicine, and we are also one of several of a national consortium of telehealth resource centers. And what that means is we have the opportunity to network with this national brain trust of people who are doing telehealth, producing services, things across the country and regionally, because as many of you on this call know, many of you do serve the people who live in the Four Corners area and multiple cultures and share some great best practices with people nationally. on a regular basis. So we have a federal grant that allows us to do that. And Arizona is very unique right now, you know, with the whole idea of being able to work with digital navigators and digital health navigators and insurance navigators. Right now, nationally, there are some amazing resources being developed, as well as right here in Arizona. And many of the folks who are leaders in this space are here on the call, and many of the folks we have been able to network with as a digital inclusion network, and people who are leaders in telemedicine and telehealth, and people who have been doing this for a long time. So the really exciting and unique thing about Arizona is the fact that we have a community of community health outreach workers, community health representatives, really based in IHS in terms of their roots, as CHOWs, community health outreach workers, and promotoras. And the really exciting news, and what I wanted to be sure to share, is now these billing codes mean that we can have the support in our libraries and the support in our community health centers and the work that we're doing to teach people technology, and it's billable. So that's going to be a game changer, and we really are leading this space in a way in which Access has created billing codes that say, I mean, you can imagine the possibilities if someone who lives in a rural area in Southern Arizona right now, in many of our libraries, people could go check out a laptop, a tablet, sign up for the opportunity to sit at a private computer, and a community health outreach worker can bill for 30 minutes of their time if the primary care provider basically writes that as a script, and the community health outreach worker has self-certified themselves as a CHW1 or CHW2. So there's a lot more information about that, but I do want to be sure that people are aware that this really is a great opportunity for us. And we've been working now, networking with folks who are my friends and family in this space here in Arizona, to create what would be hopefully a directory, and also in terms of being able to manage resource and maximize all that bandwidth and maximize all those great grants and opportunities that are out there to invest in technology and bandwidth and training, things that have never been covered by grants before. We really do have the opportunity to network, and have been working hard to create also a website to support networking as a digital inclusion network. And a couple of other great new resources I wanted to be sure to share with you include the fact that I wanted to share, if you had not heard, Mala and I are going to be sharing our telehealth libraries project with a national audience in Orlando next week, when it's going to be nice and hot there. And it's an opportunity for us to not only talk about and share our pilot in Arizona, but to discuss lessons learned and learn from other people what they've been doing. Because it's been interesting. When we first started, we had interviewed, you may remember, 4 or 5 different groups, or maybe it was like 6 or 7 different states that were doing telehealth library pilot projects, and now there are over 20. So it'll be great to catch up with others as well as share what we've learned. And our newest space in that space is Tuba City, and we look forward to sharing what that group is doing there. So I could spend a whole lot more time, but I think that it would be great to give other folks the opportunity to continue on this theme of being able to network and find ways in which we can maximize our resources, get the most bang for our buck for all this incredible money that's out there right now, to create a way in which we can provide and improve access to healthcare through technology and telecommunications connectivity where we need it the most. The other thing I'd like to share is I've been doing a lot of research, because my team will be providing a 1-day training session in Nevada this week, our neighbors in Nevada, and we've networked with them quite a bit. And they have a beautiful website on their broadband director's website, which makes it very easy to find not only demographic data, but exactly what grant opportunities there are available, and what's happening in that space. So It's been great to network and find out how we can organize information and share not only the networking opportunity to find grant partners, but find the goods to help us write the grants, make it easy to be able to pull together all the data that it takes to write an award-winning grant. And I also look forward to final comment. Usually in August, September, we hear about the next round of DLT grants, which are also a great grant round. And as soon as we hear that, I look forward to producing another webinar specifically for writing USDA DLT grants. Thanks, Steve, for having me on the panel.
Well, thank you, Janet. And I'm sure that even the other folks on the panel are going to be interested in connecting with you who may not have known you in the past. So let me get back to, you're not still sharing, are you, Janet? So let's see, where is my? Okay, so next up is Lucy Howell, and Lucy has joined us in the past and has been a great participant with us. And she is the managing director of the Force for Health Network. And Lucy, I know you have some compadres who are on this call with us today, but I'm going to turn it over to you to give us a little background.
Thanks, Steve. Can you guys hear me okay?
Yep.
Okay, and I'm not a doctor and I don't play one on TV, but that's why I like to partner with quality content creators and also top of market players. I've been a national kind of biz dev person for the last 25 years, but the last 5 years we've been able to kind of sit in and focus on something that we're super passionate about. So the Force for Health is a mixed media platform really focused on solving population health issues for both individuals and community leaders that care. And since we're like competitive, one of the ways that we wanted to frame that was in this concept of this gamification of healthy citizenship efforts and practices. And so that's what we call the reality health games. We produce content, we have an online learning management system, and we can actually create leaderboards of engagement. So my partner's in Pennsylvania, I'm in Arizona, I've got another strategic partner here in the Southeast. And that's what we're here for. I think that one of the concepts that we bring to the table is this chamber of health concept. You guys call it a telehealth network, which is awesome. But what I've come from the chamber world, and there's too many silos still occurring in the communities. You got broadband over here, you got health over here, you got education over here, you got, cybersecurity over here. There's so many broad, and I can't believe that nobody that I know in all segments know each other, right? So there is this need to have to collaborate more efficiently. I've had a chance to have kind of one-on-ones with most of these key people, so I'm super confident that Arizona has what it takes to actually be a frontline leader as we collaboratively come up with these ways to score a healthy community. So anyways, that's me, Rob, and Craig. I don't know if you want to say one more thing. I should probably say my partner, Rob, is a retired pulmonologist and has testified on both the state and the capital level as to the disparities that take place in rural communities due to broadband. Go ahead, Rob. Sorry.
I have excuse me. I have a little bit of a cold right now. I have to say though, thank you, Arizona, for introducing me to Ronald Weinstein.
That's right.
Those of you that knew him, he was my first professor in medical school at Rush Medical College where I went. And so I was introduced to telemedicine, where we hooked up a microscope in the OR to Ron's office 1 floor up, so you didn't have to run down and read frozen sections. That's how Ron got started, you guys. I've since been involved with telemedicine with the Mississippi flood, with Ground Zero after Hurricane Katrina. But the real excitement for me, I want you to be thinking about is you're talking about telehealth. And that is, you can use it for primary prevention, preventing and keeping people healthy to start with. Secondary prevention of not having an incident get worse when that person's having that stroke. And then tertiary prevention for long-term management. So there's many levels where that middle mile can prevent and have your citizenry know how to recognize the stroke to get that healthcare started right away, all the way on through to managing that stroke at home with remote patient monitoring billing codes also. I'll quit at that, but I'm especially proud to be able to observe this group and what you're trying to accomplish.
Yeah, I think that there is a definite intersection between health and wealth, and we need everybody in the community to know that. We need the private sector to know that, the public, obviously, education, healthcare, technology. Craig, he can speak later when we're kibitzing and stuff, but he's had some tremendous successes with state offices, being able to onboard and activate with some of the incredible systems that he has. So we'll kind of table that till later, Craig.
Absolutely.
Perfect.
Okay, ready to move on? So Lucy, are you sharing? You're not sharing.
I'm not, I actually could have, Steve, but I'm trying to be brief, and I want to open it up and leave it for discussion.
Thank you. So let's see who's up next. So Mohan, you want to do your thing?
Okay, well, I am probably the least experienced in compared to all of you in the specific field of telehealth, but let me kind of tell you where I come from. As Steve mentioned, I was the department head of MIS at Arizona for a few years, but I've spent basically 40 years in technology. And so I'm aging myself, but the point is that I have seen a lot of technologies come into play in the business communities, and of course, in some areas in healthcare. And while technologies provide a lot of opportunities to address problems, one of the challenges that I have seen, both the developers of technology and the implementers and the people that strategize, often fail to see the challenges of population or customers, for that matter, in using the technology effectively to accomplish the goals that we state for themselves or for those that are in their sphere of influence. So I teach in IT adoption, diffusion of technology for quite some time. And in the last 7 years or 8 years, I have kind of transitioned from purely the technology domain to the healthcare domain. I'm kind of shuttled between Michigan and Arizona. Of course, I'm in Michigan during the hot months of Arizona. But the reality is I work with Henry Ford and other health systems here, and work with a lot of nonprofits, as well as primary care clinics. And of course, I also work with some of the agencies in Arizona. But what my goal as an instructor at College of Public Health is address what we call population health in the digital age. And that is, we need to recognize that population health is not defined by a provider. Yes, that provider, of course, wants to reduce readmissions and improve wellness of the patients. But ultimately, it has to be something that a patient can actually use to self-manage their care, feel confident to effectively use that technology to be able to stay well and to communicate with both family and friends as well as physicians. And through a lot of projects I've done with nonprofits as well as health systems, one of the things I find, of course, more recently since the COVID, everybody is moving towards telehealth, even though telehealth has been in existence for quite some time. A lot of physicians are moving towards that arena in order for be able to service the patients. Of course, you can service more patients through telehealth than, of course, they come to your office. But at the same time, a lot of patients that I work with, or at least my partners work with, tend to be from underserved communities. That means they have, yes, a physician might say, hey, I have doxy me and use this particular software to be able to do a consultation, but many of them don't know how to use it. Many of them have access to problems with internet communication, and sometimes they have difficulty in using that technology to build that trusting relationship they used to have with the physician before COVID. And that means now, how do we actually make that transition to using telehealth as a viable solution, not only to educate and empower the population that sometimes has both the digital divide as well as the social and cultural divide in terms of using the technology to build that relationship and communicate, as well as the physician population that is sometimes not quite, even though, yes, they can bill a lot of billable hours because you can service many patients and you have a coach to support that. But the reality is they still also feel like they don't quite completely understand how can they effectively deliver the care just using the technology when they can't completely see the patient in the form that they normally will see face to face. So I think there are some challenges both on the provider front as well as on the patient front. Yes, we can use broadband technology and we can provide the communication capabilities, but are we leveraging the community around the patient, including sometimes the family members or caregivers? How do we kind of leverage the entire ecosystem of the patient to enable them to be able to use the technology effectively and yet have the ability for them to get the personal care when they do need through a physician interaction? So to me, it's really more about balancing act, and how do we address that issue besides technology is really what I am looking at, and that's how I normally use the students to help in understanding the challenges on both sides so that we can develop community strategies. Recently, I was on a Fulbright grant to go to Canada to do the Indigenous health by how they're using telehealth among Northern Ontario province. And again, there are accessible technologies out there to use telehealth, but a lot of Indigenous population that they interact with need a lot of cultural connectivity along with technical clinical connectivity. And that is where there is a lot of missing pieces that one need to consider if you want to make this a successful endeavor to improve the wellness of the population. So those are really my general thoughts. And obviously each case is different and each state is different and each condition is different. But really one need to take a holistic view of the patient, the community, and the facilities that they have access to, as well as the providers' ability to provide the care all together to see how best this technology can be useful. I'll leave it at that.
Thank you, Mohan. And we're going to have time after everybody presents here to go back and have a discussion among the panelists as well as among those of you who are participating in the meeting today. So with that, Dr. Payman, and I'm going to, I know you have a video you want me to share.
We can do that video at the end or at the beginning, whatever you like. Doesn't matter really.
Okay, let's see here. Okay, for some reason, Lucy, I can't get rid of you as the presenter. I don't know what's going on here.
You're presenting, Steve.
Yeah, it's showing that you're presenting.
Huh. Interesting. So on my screen, I'm just seeing Lucy. Okay, well, anyway, Dr. Payman, so I'm sharing you're seeing my screen, right? But you're not seeing me.
Yeah,
Seeing both.
Okay. I don't know what's going on here. Anyway, Dr. Payman, would you like to introduce yourself quickly and to talk about the work you're doing? And when you're ready, I will share your video.
Well, wonderful. Thank you very much, Steve. And I thank also Mr. John Bentham who recommended me to come over here, and thank you for letting me discuss with you some of the work that I have done in the past. And at the beginning, I was really reluctant to come to your meeting because I did not know the subject of my talk today, which has to do with the F4 or measuring the refractive power of the eye, has to do with the systems or whatever you are doing. But in reality, when I thought about it, I came to the conclusion that whatever has to do with the medicine, it has something to do with the telemedicine. So there is really not far away from each other. And in fact, what I'm doing, I find out now, not necessarily retrospectively, but at the beginning, I was shy to talk about it, but some of the work that I'm doing is really part to do with the telemedicine, but it's diagnostic mostly, and not necessarily communication. So I may have not worked with broadband, but I'm familiar nowadays. Everybody familiar with the communications and telecommunications, etc. So let's tell you about why I'm actually originally a retinal surgeon, not anymore because I'm retired. But I've been interested in technology from beginning. Any part of the eye, practically, I've done some work on it in the past. Now, presently, I'm just interested in some specific areas that I'm working on, and that's one of them is refractive power of the eye, how to measure it properly and how to measure it simply. Anybody who has glasses, or Steve, you see, you have glasses, and Juan has glasses, and a lot of people have it, even if they don't have it on their eyes, on their nose, basically. They have gone and seen ophthalmologists, and it takes time for the ophthalmologist or optometrist to check their vision and measure the refractive power. And very often here and there, they ask you questions about this and that, and take more or less a lot of time to come to a conclusion. Some people cannot do that even. But before I get into that, I just wanted to tell you what the scope of the refractive error is. It might get a little bit pick up your interest in the subject because it's really interesting. In the United States, we have about 1 million people who are blind, actually. It means you cannot see objects, which we call it better than 2400. Or generally speaking, the measure is 2200. It means an eye which can see properly sees 200 distance, 200 feet distance was a person who is handicapped sees only in 20 feet for that matter. Now, the numbers are, as I said, staggering because 1 million blinds here, and we got 3.2 million people are actually visually impaired. A lot of them even don't know that. They're just satisfied with what they are doing. Among the population, there are about 8 million people who are actually have never been to an ophthalmologist, and they just live, do whatever they have been doing. If they can see well or not, nobody knows. And basically, they may not have the means of seeing a doctor for that matter. The problem is not necessarily more limited to the adults. Children, they are born with the problems, and gradually, as you know, a lot of children, the eyes are not properly, basically aligned properly, and they develop amblyopia. That means one eye cannot see because they are not focusing on the subject, but one eye can see better than the other eye. So we call it amblyopia, or they have some diseases. In general, people in the United States or other people, majority of people who are visually handicapped, etc., unfortunately, also can be treated very nicely. In reality, 50% of people with visual problems can be very easily corrected if they are diagnosed. And diagnostic starts with measuring the refractive power of the eye. So that's really important part of that. And very often, unfortunately, people like people who live outside the cities, or maybe Native American or other people who cannot afford to see a doctor, they never have been examined by one of these units that we have. We call them phoropter. These are big units that they put the person behind it, and they look through the oculars, and they want them to see some visual display that's in front of them in the distance of 20 feet for that matter. And subsequently, if they want to read it, they hold something in front of them within about 33 centimeters. Now, the unit is really basically big, heavy, bulky, also expensive, and not really transportable. Once you have, in my life, when I saw a unit for up to some place in a part of the room, it stays there till the end of their life, basically, which is end of the time a person who is going to live there and give it to somebody else. The Phoropters have been invented more than 100 years ago, so not of much had been done. And I was really frustrated with that because a lot of people are. And I was on the receiving side because I was trying to correct the refractive power because they had some problem with the retina or cornea or other things, or the lenses. And the refractive power that was measured were never accurate. So I was frustrated by subjective quality of the things, and a lot of people, really elderly people and so on, maybe Native American, they really could not properly communicate with the people who were measuring the refractive power, and everybody was tired of it. You know, they put some lenses in front of you, they turn these knobs around it for up to 100 or more than 80 lenses in each side of these machines, and then turn it around and say, this is better or that better. They are looking at an object, but they have to remember the memory to tell them a very finer differentiation between the 1 and 2, etc. So which is all nonsense, basically, from my point of view in this moment. So the Phoropter have not made progress. For that reason, I felt when I came to Arizona after hurricane came out and basically took everything away from us, including house, office, and laboratory, everything. And I ended up in Tucson, and I thought maybe the best thing I can do to line up with some optical engineers. And I had some design in my mind to remove the Phoropter because it's just basically not useful, very subjective. The concept that I developed was that to remove, actually replace all the lenses in any of these Phoropter with 3 only lenses, which are basically, we call it a spherical cylindrical, with 2 cylindrical, 1 spherical, which are actually can be expanded and compressed to making it small. We call it fluidic lenses. So having a fluidic lenses, that means we don't need to have all this machinery. And the second, I wanted to make it automated. That means we don't have to ask a patient how good or bad they are seeing. We just tell them to look at this picture or the matter in front of them through the goggle, and then they can look at it. They don't need even communicate with me or the doctor or the nurse, etc. What happens is that the light beam goes inside, hits a mirror, and part of the mirror the light gets inside the eye, and the light comes out of it. That light that comes out is transmitted through the fluidic lenses to a sensor, which is called shock hardness sensor. That shock hardness sensor has maybe a lot of small little lenses in it, which more or less measures the position of these lights and can differentiate between normal and abnormal. And then we connected this via software to the fluidic lenses, and the machine really decides that the lens is not seeing things properly. That means I'm focusing on the distance on the chart. The eye cannot see that properly. So that automatically corrects it and instruct a pump to fill up the lenses in front of my eye, which I don't see that basically. And it increases and decreases to the degree of refractive power that my eye sees. And the machine itself sees it. Now it's corrected. No communication between the doctor, patient, etc. No question asked. And the data is obtained from the Shackleton system, is recorded. And recorded is basically transmitted either to the doctor or to the patients or whoever have been responsible for that. We can tell them to do what to do. Now, at the same time, I want to tell you what has to do with the telemedicine, because until now, these corruptors were so much, so heavy, nobody can move it around. Now, the system that we have, we can put it in anybody's house that they want, basically. After surgery, a lot of people, the eyes or don't know if they are better or they are worse, basically, and they are what them. The doctor tells them, you go home and come back about a month. And the patient doesn't know how it's had to be worried, am I better or not after all these surgeries and all these things that I have done. But this machine can really basically do it if they haven't temporarily maybe rent it for a while and put it there, and then gives them the information about the visual acuity. And the information also can be transmitted to the doctor via internet. Basically, that's what the telemedicine does. And the doctor looks at it and say, well, you see that you have actually improved, or is the same, or you are worse. Therefore, you should come to see me. So that solves the problem. That's simultaneously solving the issue of a refractive power and simultaneously having a telemedicine system. So why am I speaking to you here? Because John felt that maybe that would be helpful, because I was looking for some assistant to move the concept that I have, not only is conceptually, obviously, in this moment, but forward to the FDA, etc. Would you mind, Steve, showing the movie now?
Sure.
A series of one of some of the co-workers we have, they come on in front of the machine that's in front of them, and they bend in front and look through the system, if you can show it. And then you will see how long it takes to check the visual acuity of a person. And once it is shown, and the machine tells them you're done, your refractive power is measured and it comes back. Now you will see it here, the system, the company that we got is called ICRX. The system is Optrix, this is our own name, and this gentleman is sat in front of it. This is what the computer sees, basically. And below that, you see the numbers. Numbers that you saw, that is refractive power of his left eye. As you see it here, and again here, and I want to right eye, I'll turn the channel also to the right eye. So this is the time that takes to see the visual acuity, measure the visual acuity of the person. That's what also the patient sees. You look through it, you don't ask any question. The machine automatically corrected that, and then the visual acuity measurement is concluded. So we got the machine set and we went to the FDA. FDA asked us, we said, are you manufacturing or are you making it? I said, we are making it. They said, no, you should manufacture it before we approve it for that matter to be used by other people. And that's why I was trying to bring it to your attention, whoever pay attention to that. We needed some help financially, obviously, to develop this, because that manufacturing takes really requires some investment. But this system really can be used nicely for screening of children, screening adults, for more or less everyone wants to have it, take it on to the developing countries, and communication can be done also through the internet. We are still working the internet part of it. We have completed the unit, and that's what that is. So I wanted to bring your attention. We are having presently a system here that can measure the refractive power very short period of time, probably less than 5 seconds. Now, the number moved on 20 seconds here in case people can't see properly. So that's what it is. There is no communication. You don't have to kill yourself or the patient in front of you. So you just measure accurately the refractive power, in fact, better than subjective refraction. That was it.
Okay. Thank you.
You're welcome.
Okay, so now I'm going to open it up to, let me stop sharing here for a minute. Let's go to. Gallery view. Okay, so let's open it up. Any questions, comments, thoughts people have from what you heard today?
Steve, this is
Yes.
Marla.
Yeah, Mama.
I'd like to add to what Janet talked about, telehealth and libraries. We had our first study done last week. And I know this will be relevant for this group, and it's just hot off the press. In fact, I got an email about a report about it just about 10 minutes ago. So I'm sharing it with you. This is a study that we are doing with Navajo Nation. And when I say we, it is the state library participating through its telemedicine program with NAU, U of A, and with a grant from NIH as well. The state library used its LSTA grant funding to provide backpack kits, telemedicine kits with things that they could use to do the vitals, like the blood glucometer, the pulse oximeter, BP cuff, thermometer, weigh scale, etc., and a stethoscope that can connect via the computer to a doctor remotely and with the software that it can use. And I'm giving you this background for this group because I've already spoken about this in detail at other meetings, AZBSN meetings with Janet, of course. So we already piloted this project both at Pima and at Aho, but the study itself that we're doing with the Navajo Nation is the first one that we are doing of its kind in Arizona with the liver scan study that we're doing. So the first one was done at Lychee Chapter House, where we had installed fiber connectivity just a few months ago, actually, with E-rate dollars. We have good connectivity at some of these chapter houses, not all of them yet, because we're still working on that. And the goal was there were several goals. One was first to introduce the population in and around to the availability of the telemedicine equipment, which we have at Tuba City for that group. So the equipment was taken from Tuba City to Lychee Chapter House, where they did this on July 5th, 6th, and 7th. Their goal was to study a minimum of 20 livers, and they got 29 participants. They surpassed their expectation. They promoted this to the local population, and 29 of the participants showed up and had the liver scanning done. The goals, as I said, one was to first educate the population, show them how the liver works, what risk factors are there for diabetes, obesity, for those that had diabetes, obesity, smoking, elevated BP, cholesterol, high cholesterol, or genetic influences, all of those, and how they affect the liver. That was the education part of it to this population. Then the second part of it was the scan. The doctor scans the liver, the nurse practitioner helps scan the liver, and the scan goes to the doctor, who is remote, who looks at the scan and makes notations for the nurse practitioner to talk to the local participating patient, and then the nurse practitioner discusses it with the patient. They also have to fill up a culturally sensitive questionnaire on their lifestyle, and they are also told about the availability of this for follow-up, at the Tuba City Library, because the equipment is made available to them if they need to do any follow-ups. So we're going to do the next event, July 17th to 21st at Kayanta, and a third event from July 31st to August 4th at Tuba City. And both these places, there is a target of about, another 80 patients at least. That is 40 in Kayanta and 40 at Tuba City. And the result of this study will be posted to NIH and used for preventive measures for those who are likely to get liver cancer. So this is one of the first ones that we are doing in the state. And we've had, I should be getting pictures for our next meeting, which I'll share, and of course to present at Orlando as well. So back to you, Steve, and any questions I'm happy to answer.
Very quickly, Mama, would you be kind enough to post a link to that story in the chat, please?
We don't have a link yet because, like I said, it's just hot
Okay.
off
Okay, no worries.
hot off the press, I might say. But
Thanks.
once we finish the 3 studies, we will be posting it both. We have to post it on the LSTA for the LSTA grant. The state library has a grant from the libraries for the libraries from IMLS, which is the Institute of Museum and Technology Services. Since we received the grant from LSTA for a part of this study, we will be posting the results of it there as well. And certainly on the NIH website, but it's not ready for it yet. I know that
No
it's
worries.
relevant to this group, and that is why I mentioned it. It's one of a kind. It's a unique study that is being done. And it's another way of using telemedicine through libraries for the health of the population.
Any other questions for Mala? About for any of our other presenters today? Any other questions, comments, thoughts that people have?
I made a quick note on everybody that said something like Dr. Mohan, you're absolutely right with the fact that we have to deal with maybe a familial or an ecosystem type of approach to bridge the gap within the digital inclusion space. It's more than just broadband, and they have to know how to get to it. So totally on board there. Janet, when you talked about building CHWs and building more people, one of the gaps I think at the hospital, at the library telehealth hubs, were kind of like, who can we go hire and maybe train to perhaps facilitate those private telehealth hub consultations in public. So building the ecosystem and making sure that these young folks are both taking care of themselves first preventatively, but then also maybe growing a more diverse healthcare workforce, I think is super important. And I love that Dr. Weinstein has something to do with my partner there, Rob. The third thing was Craig settled. So of course, like telehealth matters, it saves lives. And so that's really what I want to just put on a big flag and make sure that everybody understands. It's not just utility anymore. It's not, it's not just a luxury, right? It is actually a divider right now. The longer people go without digital inclusion, then the more likely they will fall into lower class, middle class, and high cost preventable chronic disease. Okay, so I want to make that strong and big. And then with my ophthalmologist, first of all, the inventor of LASIK, hello. Congratulations on that when I saw that. One thing that we have been focusing on for kind of telehealth and prevention in the senior space is fall prevention. And fall prevention has a lot to do with visual acuity and the ability to use the brain. And so, just an example of I took away one key thing from each one of the folks, and those are what I was zeroing in on. I just wanted to share that.
Thank you,
Steve,
Lucy.
I have a question. Actually, I don't know if this is for Janet or whom it might be addressed to, but with respect to the telemedicine centers or hubs, if you will, at a library, what disciplines, I'm just curious, are you looking to have covered? So for a remote library, a state library in Tuba City, what disciplines? Is it ophthalmology? Is it, heart medicine? What types of instruments or what types of services are they looking to have hosted at these different centers?
Janet, do you want to go? Or?
It's definitely a Janet Major question.
Yes.
We have I was trying to find a picture of the kit, but it's basically a box to go for the libraries that we've written the grants for. Now, our libraries are very French Canadian like me. They are all separate but unique. They all have different resources. So it depends upon where you go, what resources are available. But what we have piloted with Tuba City being our third site is a kit that has a digital scale, blood pressure cuff, a laptop with digital stethoscope software, a small set of equipment in a box to go that's being used within the library space. Now it's connecting people to their existing providers. It's connecting people to whoever they want to connect to do healthcare. It is not recruiting people to anyone's specific service. If someone's healthcare provider currently is providing services, that's really optimal. It's also to connect people to a diabetes website where they can keep their own health logs. It's to apply for jobs. It's to sell their stuff on Etsy. The equipment isn't just limited to healthcare, but the healthcare packages that we put together are specifically bundled with a medical grade tent and tables and chairs so that we can send interprofessional teams out and teach people how to use these devices. And the librarian's role is to manage these resources just like all the other resources they manage. So the really critical piece of it is the local community health centers, the local community health outreach workers, volunteers, people who want to help their neighbors, teach them how to do their own blood pressure. And it's interesting because across the country, it's very much at a lot of different levels in a lot of different libraries, where some beautiful kiosks have been installed in some library spaces, and some really small single person kiosks in other places. There are some kiosks available in some libraries to give people that private space. But it's interesting because it does vary. And of course, without the telecommunications connectivity, we would not have that. And the thing that's great about this study, the work that's being done up in northern Arizona, is the fact that that really is the result of getting those chapter houses connected and getting that bandwidth available. And I see that Erin has her hand up to comment as our digital navigator expert.
That's all I wanted to add, that really the library's role in this is the role that libraries have had forever, helping people learn the tech and connecting to the internet and giving them a space where they can have potential private conversations and all of that. So the library itself doesn't engage in the healthcare or any of that side of it. It's purely the connection to the resources and the materials that they would not otherwise have access to.
And the reality is, someone could prevent a 5-minute pre or post-surgery checkup taking a 3-hour drive on top of that. That's why the electronic stethoscopes are there. It's great to take someone's vitals. Your clinician is not going to not listen to heart sounds and think that it's fine if you're getting a pre or post-surgery follow-up. And one thing that I've learned throughout the many years that I've done telemedicine is there are absolutely some specialties that lend themselves well to providing those services to people in remote areas. And that's one of the reasons our program really exists, is so people can be copper miners and sheep herders and live in rural spaces and still have access to a rheumatologist or a dermatologist or something that might lend itself well to a tele application. And teleophthalmology has always been really big here in Arizona because we can cut those trips in half by using a non-mydriatic camera and screening people in their hometown. So they're only traveling if it's necessary for follow-up. And I see another hand up.
Well, yeah, I think one of the studies we are doing in Michigan is providing African-American population 3 digital tools, Fitbit and blood pressure cuff and weight scale, and through an app, provide them the ability to monitor and share that information, not with the physicians, but educators. But one thing we found is that they don't necessarily go to libraries as much as they go to community care centers where they interact with others socially to build a peer communication, peer networking, to get reinforcement to what they are doing and to get some encouragement. So I think the whole concept of creating these engagement facilities need not always be libraries, could be any entity that is allowing people to connect and allowing them to be able to interact not only with physicians, but also with social groups. To me, that is really one of the key things that often community engagement piece misses. We only often focus on physicians and patients, but it's really the patients and their community, whoever they consider as a community, a trust building personnel. We need to start building those connections as well. And whether that is telehealth or through some other technology, you really need to build a social networking facilities for them. So I think it's a combination, and which facility is the most appropriate may depend on what the nature of the population is and how they want to interact with others.
Absolutely. And I think you think about the food bank and what an awesome place that is to reach people with diabetes education. And we do have libraries that have a community food garden right next door. So the county health department's a great place to outreach, and also cooperative extension. They're in every single county. And I think that's how we maximize and get the most bang for our buck. Molly, did you have your hand up again? Or are you just still? Yeah.
Yes, actually, I wanted to answer Mohan's question about why libraries, because again, libraries and schools are considered community anchor institutions for E-rate purposes and have really good bandwidth to do this, which is important. As a technology person, I know you know that already, and especially if it is video transmission, that is really important, and we need good gigabit speeds wherever possible. And that's one of the reasons why we waited almost 2 years to do the study in the Navajo Nation area because of connectivity issues. Having said that, now there is a lot of BEAD funding, which is the broadband funding that is coming to the state, and a lot of the other community anchor institutions will have access to the middle mile. They may not have access to the last mile, they'll have to do it themselves, but the middle mile at least will be available. And we agree, I agree 100%, and Janet, I know it does because we've been discussing doing not these one-off events like I posted on our chat that we did to start these programs both at Pima, at Aho and Arhuaca, but to continue these, like having a Thursday, a telemedicine Thursday, a telehealth Thursday at the libraries, so that we could invite the community to be there to do whatever we do that Thursday. It could be an eye test Thursday, where we have lines come and do eye tests for kids, but at the same time, the parents who have kids that have issues can get together and the library hosts the event, and they can talk about the issues that they are facing, the social issues they face with their children with poor eyesight. The same could be said of diabetes or any other health issue or autism or anything else. So we were looking into making this available as a community event at the library. And libraries are, as we all know, trusted places where the community meets. So we're hoping that we can continue this through that.
Okay, so John, and then we got to get to Kirk because he's just dancing. So John first.
Yes, I really wanted to add, I've been working with Dr. Payman a little bit on the information around the 4-opter. It's actually an automated 4-opter, and I think it's a perfect fit for the library system or a community center because it does not require a physician to either activate it or implement or do the testing. Someone at the library could administer the exam, which takes literally 5 seconds. As you saw in the video, they sit down in front of it, and within 5 seconds, they have a full prescription and an alert of any possible eye diseases that they may need to have taken care of. And that information can be sent to their primary care.
Okay, Kurt.
My question's with all this explosion of telemedicine, which makes an awful lot of sense for a lot of reasons, not people that are remote and triaging and so on and so on. Is there a big push in product development and technology to where you can put more and more wearables tied into Bluetooth into a laptop or your app and get a lot more information flowing real time to the clinician or whoever's doing the appointment? I would imagine there's got to be a huge product development push in that space. I was just curious if you could comment on any of that.
There's a lot going on in that space, and the US Army does amazing things. I remember 15 years ago seeing a dog tag that was like basically a card out of a camera that would have your entire medical record on it. And, some things make it to market and some things don't, but there are people that come up with creative solutions for like a glove that's a 12-lead EKG, or things that, really are very future thinking in ways that we can keep down the cost of healthcare and keep people in their hometown. The thing that's really kind of reining things in a bit right now, which was really very evident at the American Telemedicine Association, is AI and the use of data and how much is too much. Having your every movement monitored for your health is great, but when you want your every movement monitored, right? So it's an interesting frontier right now. And people are coming up with amazing stuff, especially here in Arizona. We've got really amazing biomedical engineers and the whole downtown biosciences campus and the U of A Tech Park. There are people coming up with really, really creative solutions in terms of technology, but it's got to be a solution to a problem as opposed to a really cool device looking for a marketing plan, looking for a business plan. And sometimes that seems to be the challenge, small devices that connect 8 different vital signs and then, but unfortunately then marketing that, it comes with the network and the bundle and the provider and everything when you think all I want is that device. So, the business model is very challenging in telemedicine, telehealth. And I think who's an expert? We have a local Arizona expert, and that is Joel Bartholomew, is a wonderful local expert on FDA approval and getting things to market.
And I think I'll just kind of add, we've been working with some mixed generational kind of STEAM teams that we see teenagers help seniors connect digitally. Once that connection is taking place, it's a beautiful, beautiful thing, because now the seniors or the disconnected or unconnected can play in the transfer of information that can actually improve their health and wealth. But the thing is that everybody gets so excited about these things, and the disparities are happening where there's low economic flow. Okay. And so, yeah, you can talk all these different wearables and stuff, but unless somebody's going to write the check to go ahead and put them on, and then you go up against, FERPA and HIPAA and all these different, there's a line that's doctor patient versus commercial health, consumer health. So that's what we have straddled with, Rob and I. We are a for-profit media and digital health publishing company because we play in that space of, we want to advocate. We want to kind of be free to do whatever we want to as we try and improve health here. I didn't see Rob leaning forward.
I'm just, excuse me, I'm just leaning forward with this. I'm so sorry. See, if I had a good library, I'd have the kit. You could look at my throat. But the truth of the matter is, you don't need a kit for about 70 or 80% of the things. You need a health literate person who knows what pieces of their history and what findings on the physical. Just a good history can solve a lot. And that's where telemedicine with a telephone has been happening since the 1920s in some regards. Take 2 aspirin, call me in the morning. You had the camera. It's another thing. You had the kit. Now that you have a kit and you're talking about a trusted person, a digital health navigator who's trained in the use of that kit, who is a trusted community health worker, someone from the community or from their own family that can come to that appointment, so the librarian isn't forced into a position of trying to be a health intermediary of some sort. So it begs towards training teenagers to retired seniors to be community health workers, digital health navigators. It begs towards training everyone to be health literate enough that they can really share information that would help that doctor come to a diagnosis. One last point here I think that I'd like to make with is there's a whole nother bucket of money and opportunity here. And that's STEM education. What is more exciting to a middle school or high school student than their own body? Come on, that's all they care about. How they look, how they feel, how their body's changing. If they have access to a pulse ox, a thermometer, a blood pressure cuff, etc., science curriculum and experiments on their fitness or their nutrition or their activities, STEM education can get a next generation where all these devices and the physiology and anatomy becomes a natural. So thanks, especially libraries, great place for STEM education workshops, teacher developments and such.
Mark, what's the STEM event U of A medical school used to put on downtown? I don't know if they're doing that every year again, but the kids got super excited at that event.
The person that was running it is no longer there.
Yeah, that was a great event because I mean, and you're right, Robert. The kids just got super excited with everything that was medical related and stethoscopes on their friends and everything else. I mean, it really inspired them.
Yeah.
What was it? What was that event called?
Rika, did you have something else that you wanted to add?
Yeah, I just wanted, because I know there's a lot more disparities, of course, with people of color and low income, but there's also educated people of color that don't trust the medical field because of the lack of trust in the issues we've had or experienced with doctors and that. And so to be on, I think for telehealth and to talk to somebody, they're only going to want to talk to a trusted person. So it's not, they're going to, because of the challenges, I know me personally have faced with doctors, and I've had to change doctors because I've had to advocate for myself. And so how do we start teaching them to advocate for their health and know that what you're feeling is wrong and it's okay to say it's wrong? I literally have to advocate for my 32-year-old niece because the stuff the doctors are telling her, I'm like, that don't sound right. So how do we also bring that conversation to light in regards to how to advocate for yourself when you're a person of color?
I got news for you, Sharika. You don't have to be a person of color to have to do that. You know, my wife has multiple health issues, and we go through doctors and all kinds of different doctors and have to advocate for her all the time. It's an interesting experience. JT, did you have a comment?
I did. I had several comments, but one of the comments that I wanted to just, I think the last speaker, Sharika, you know, she brings out the point that in our community, I'm an African-American senior with a variety of health challenges that you might expect for an urban African-American over 60 years of age. And there is a mistrust of the medical profession among African Americans, and you don't have to look back that far in history or even to the present time to recognize that. So that needs to be overcome, and it is something that needs to be overcome. The other thing I wanted to go back to was in the conversation about libraries, and I think the gentleman from Michigan mentioned that you know, I think, and I don't let me put your words in your mouth, sometimes you don't see African-American participation in libraries because we don't go to libraries. Well, part of that is because even in the hometown where I grew up in Michigan, the library was not welcoming to us. It did not have the types of resources that we went to libraries for, and we had to go to bookstores to get the kinds of materials. So as you all are planning, you know, these for these different equities in broadband, healthcare, telehealth, you have to understand, obviously, and I'm not saying that you don't, but there might need to be a greater attention paid to your constituencies, those persons that you would hope to serve, because things that you might take for granted in the environment in which you're familiar in working is not the reality of some of the people that you would hope to serve, and you won't see them because they won't be there.
Did we lose Mohan? Mohan, are you still there or are you gone? I think he's gone.
That
I'm sorry, go
very
ahead,
quick
Lucy.
feedback to you, JT. We have a program called Advance the Dream, hyper focus on minority health disparities. And we're finding most of our activities in community activators that we're working with are tied to faith-based communities. And so there's probably 5 examples of that throughout the country where it's been very successful in utilizing that faith-based connectivity and instant community and trust makers. So I hear what you're saying loud and clear. My partner and I did an implicit bias training for the state of Ohio Medicaid to see whether or not they were implicitly biased when treating African-American and brown skinned women. So we hear that point loud and clear.
I think something that we need to talk about when we talk about equity is the fact that, you know, I'm all on board and I keep singing and dancing like many of you about the Affordable Connectivity Program, but is it really equitable? Is there really equity if people are still paying $30 if they don't have $30 to be connected to the internet? Is it really truly equitable to think that there are people who not only will never have the internet in their home, but will not own a device to use the internet in their home? And I think that that's why we really have to be forward thinking in terms of how can we create equity? We can create access to healthcare and improve health equity by having the opportunity to share connected devices, and by having places like our libraries, our community health centers, our food banks, our health department, whoever does it, help manage these devices. I think that has to be part of our investment if we truly want to have equity in our future.
Brilliant.
So that's my wrap.
So I think that one of the things that's obvious, and of course, Janet, you know, the telemedicine program has been around for a long time, but this now moves into a whole new realm of outreach that creates a whole, as we know, with all technology and new technology, creates whole new challenges and things we never even anticipated. And so we'll figure it out, and it's very exciting times, but it's we still got a ways to go. So anyway, any other questions or comments for anybody? Okay, well, I think I'm sorry, somebody going to say something?
I was just going to say a quick note that we have recently formed My Healthy Broadband Executive Community Chat Resources and Challenges. So we will be putting this on the docket once a month and having a standalone a session on this. So happy to have anybody join. And of course, you know, Steve, I'm kind of following your lead here in Arizona, but this needs to have its own conversation and why it's so important. I wish I could snap my fingers and just have the state pay for everybody to have access and bypass the whole NTIA $30 stuff. You know, it's like, how can we just get everybody connected? But anyways, I just wanted to make that note that we'll be hyper focusing on My Healthy Broadband issues with the Force for Health Network coming up here soon.
And
And Lucy for president.
I'm sorry.
That's how we fix it.
Lucy, where do we find you guys?
The forceforhealth.net, you know, I'm going to go ahead and give Steve a follow-up link to all of this. I'll put it in the chat also. But yeah, I'll put it in the chat, theforceforhealth.com. And then I will follow up with our Healthy Broadband. myhealthybroadband.com actually goes to our site, but I haven't published the page yet. But we're hyper focusing in Ohio, Pennsylvania, Arizona, Florida, Illinois, and California. So Arizonans, come on, I need us all to step up and get to brag a little bit about this collaboration.
Cool. Anything else? Well, I'm going to stop recording, and I don't know if people want to hang around and chat, but officially our meeting is over as of today, as of now. And thank you to all our presenters. It's very exciting to see all the exciting stuff that's happening and growing by leaps and bounds. So thank you all for participating today.
Thanks, Steve.
Thank you.
Thank you, Steve.
Thank you.